Welcome back to Diabetic Book Files, where what we expose is what pills are trying to tell you. And today's episode, I guess, is from me doing some research, and I hope everybody had a really great Sunday. But today we're going to talk about something that I don't think people fully realize, in that podiatry, I sincerely do believe, is the number one specialty for early vascular exposure. And I've never heard anybody say it, so if you hear somebody repeat it, okay. But, I don't mean like we see vascular disease sometimes. We actually see it quite often. And honestly, they sh- podiatry should be probably the number one people to refer to vascular, because usually a lot of vascular problems do present in their feet even before people start even thinking about cardiology, unfortunately. So even before cardiology, or the person gets the vascular surgery, or even before the primary care doctor catches it, or even before the ER catches it, sometimes it's the podiatrist who catches it. And podiatrists usually are the first physicians to physically see, touch, and document any symptoms of possible ischemia before anybody else does, in my opinion. But everybody has their opinion. I do believe that every healthcare provider does their best to make sure that we refer to the right care and specialty. But today we're going to talk about why that is true, because actually it was in a research article that I found, and the anatomy and the pathophysiology behind it. I don't think people really understand exactly how important podiatry is, because we all have feet, and we have two of them, and you need them to walk, right? And why early vascular exposure changes amputation rates. Okay, just the whole point of this podcast is for amputation prevention, right? So why do I believe, or why does it seem like the foot is one of the first organs to show vascular failure? So peripheral arterial disease, PAD, doesn't start in the heart. It doesn't start in the leg even. It starts with, they call, microvascular level. And I guess what structure is the furthest from the heart? The toes, right? And by the time a patient has shiny skin, hair loss, thickened toenails, dependent rhubarb, delayed capillary fill, and dorsal pedis pulse changes, disease is already brewing there for years. And who's sobrining the callus? The podiatrist, most of the time, right? And who's trimming the toenails? The podiatrist. And who is seeing the ulcer that is 3 millimeters before it becomes 3 centimeters? The podiatrist, usually, right? Because it starts from the foot, and the person thinks that they have to go to the podiatrist, right? Because that's the foot specialist. So why does the podiatrist see it first, in clinical reality wise? Let's be honest. So a lot of people, they rarely remove the socks. Let's be honest, okay? In your visit, they rarely say, "Remove your socks. Let me see your feet," right? In any other specialty, really, right? Besides vascular, but cardiology, they listen to the chest. Vascular often sees the patients when they're critical, and they usually depend on our referrals, right? Nobody just says, "I need to see vascular." And also patients' insurances, depending if they have a HMO or something like that, they have to get a referral from their primary care provider, right? So podiatrists, we're physically inspecting the plantar surface of the person's skin on their feet, the patient's nail beds on their feet, the interdigital spaces, the callus formations, the temperature gradients between the feet, and the subtle changes of color in their feet. So we're able, as podiatrists, able to detect early digital diagnosis, subungual ischemia, pre-ulcerative lesions, and capillary refill delays, which is a very easy test to do. You just do a little pinch and you see how long it takes for the capillary to refill. And we see them on a routine basis, especially with diabetics. And so the early detection window for podiatrists to get patients to the vascular is pretty much everything. So let's talk about the pathophysiology and why early exposure, and that's why podiatry is such an important field, matters. So let's go deeper. So peripheral arterial disease, of course, as we know, is a progressive narrowing of the arteries due to atherosclerosis. So think of endothelial dysfunction, which leads to lipid deposition deposition, and that leads to an inflammatory cascade, which leads to plaque formation, which leads to lumen narrowing. And so by the time an ulcer forms in a diabetic patient, you already have neuropathy, microvascular compromise, macrovascular stenosis, impaired nitric oxide signaling, and reduced oxygen diffusion. And so the tissue oxygen tension drops below the healing threshold, which is around 30 mmHgs. So if we intervene early, such as doing an ABI testing, toe pressures, a toe TCMO, vascular referral, that's why I always refer patients to vascular, compression modification, and offloading adjustments, you can change the trajectory of a patient when it comes to amputation prevention. And that's why I get so sad sometimes when I hear certain people's stories about their amputations and their foot just turning black all of a sudden. And I'm wondering in my head, when were you ever referred to vascular? And I always say, especially even the patients that are low risk, you need to see vascular at least once a year at least, okay? Especially as a diabetic, okay? But what happens if ischemia is ignored, right? Ulcer formation, infection, possible osteomyelitis, possible gangrene, and possible higher risk of amputation. So why is early vascular exposure great for amputation prevention, okay? Strongest data in limb salvage shows that early vascular assessment equals reduced major amputations. So, in fact, the multidisciplinary limb salvage team, where podiatry is involved early, shows significantly lower above the knee amputation rate. And why is that? Because podiatrists as with podiatrists, we identify wounds earlier. We detect ischemia before tissue loss spreads. We push for revascularization sooner. We document the progression, and we're just not just the foot doctors. We actually like help refer to vascular because we should know to refer almost every patient to vascular, especially a diabetic patient. They should definitely have a vascular on their team no matter what. The moment you're diagnosed with diabetes, you should have a vascular doctor no matter what, even if you don't have any vascular problems. You should be referred to vascular so they can just do a workup and that you know in the back of your head that that is something that is at risk, yeah, and that you should always have a yearly checkup with vascular if you're a diabetic. That's my theory, okay? So why does this matter? So in certain countries, like let's say developing countries like the Bahamas, diabetes is a high prevalence, amputation rates are high and devastating and kind of like a default. Kind of sometimes here, that's what it seems like. And access, forgive me, access to vascular intervention can be delayed because of the resources are limited, okay? And sometimes podiatry is underutilized because patients discover that, hey, what is a vascular doctor, right? Because vascular disease can be discovered late when patients don't utilize their podiatry as often, okay? Everybody who has diabetes should have a podiatrist. That's my theory, okay? And we're not just trying to negotiate between a below the knee amputation and a above the knee amputation. With early podiatric evaluation, that means you get to get tested for ABIs earlier, you get to get vascular imaging earlier, earlier lifestyle intervention, earlier medication optimization, and earlier revascularization referral. So pretty much having a vascular referral early, especially if it's done by your podiatrist, because like you might just have cramps in your foot, right? And your podiatrist will check your pulses and notice that your pulses feel faint, they're absent. Let's say they do a Doppler, they notice it's monophasic or biphasic, and they refer you to a vascular. And you just had cramps in your feet. That's it. Nothing, no ulcer, nothing like that. And then when you get referred to the vascular, let's say they do arterial duplex and they realize that there are some stenosis, okay? Or if they do an ABI, things like that. And you'll be able to detect something really early and be revascularized in time before it gets too late. You know, we don't want it to get to the point where you already have a dusky appearance in your toes and, there's a cap refill delay that is significant and that a toe is already turning gangrenous and having tissue ischemia. We don't want that. We want it to come in the moment you have anything wrong with your foot. That's why I love podiatry so much. So why is there a myth when it comes to just saying it's just a callus? Because it's not just a callus, right? That's one of the most dangerous phrases I believe when it comes to medicine saying it's just a callus. It's not, in my opinion. It's never just a callus. Under a callus, I always told you a callus is like a waving flag. It's just telling you something is definitely wrong. There's too much pressure, something is going on. Okay. There is an imbalance somewhere, some way, even if it's biomechanical, right? So under a callus, there might be subdermal hemorrhage, might be ischemic tissue, might be a pre-ulcerative necrosis, might be early gangrenous changes. But a podiatrist removes that callus and sees what's underneath. And that's early vascular exposure. And that's how limb salvage can be done in real time. So, what are some of the vascular problems that present in podiatry? What patients think it is and what it actually is? Because I really do believe sometimes when patients come to the podiatrist, they're not fully aware that they're experiencing is a vascular problem. They just think something is wrong with my foot, something looks weird, something feels off. Okay, but they don't automatically think that it's a vascular problem. Okay, they'd be like, who's that? What is that? What field is that? Right? So, like I said, one of the most dangerous things about vascular disease is patients don't walk in to the doctor saying, I think I have peripheral arterial disease. I've never heard somebody walk in and say that. They would say something like, I have a wound that won't heal. My toenail won't heal. The doctor took my toenail off and it won't heal. Other reasons for that too, but still, I have a callus that keeps on coming back. Oh, my feet feel cold. My sore won't close. My toes are turning black. I thought it was just neuropathy. And this is how podiatry comes in the front line of things, okay? So how else? What other symptoms do we see as podiatrists? Claudication. So claudication is like calf pain when walking. Rest pain. Rest pain is like it's worse at night. It improves when the patient hangs their leg. Cold feet, shiny skin, hair loss on the toes. That's why you'll hear me ask the patient, do you shave your legs or do you not naturally do not have hair on your legs? Thickened toenails, delayed cap refill, diminished or absent pulses, dependent rhubarb, or pallor on elevation. So let's talk also about critical limb ischemia. So critical limb ischemia is an advanced stage of peripheral arterial disease. So when a patient say, I can't sleep because my foot hurts. Or if a patient says it feels like my toes are on fire, or it gets worse when I lie flat, or when I can dangle my foot off the bed. Or what else would we see with patients who have critical limb ischemia? Things like development of a black eschar, it's like a black flack on their skin, right? Adherent one, gangrene. Gangrene is the tissue necrosis. It becomes black. It looks mummified. Remember, wet gangrene is very serious because it means infection. There's dry gangrene and there's wet gangrene. Necrotic digits, severe rest pain, a patient having a toe pressure that is less than 30 mmHg, a non-bleeding wound bed, that's a problem. So I know a lot of patients do have a problem with seeing blood, but blood is very, very, very good. Okay, it's good to see blood coming from a wound bed. Okay, we're not saying it's squirting out like you nicked the artery, but the wound bed is supposed to be red, beefy, bleeding wound bed. That's healthy. Okay.